Hi there, and welcome to the While You Wait podcast. We work to bring you stories of humanity, care, and hope from across the Arkansas healthcare landscape, all while you wait to start your day. Our series is hosted by the staff of the Arkansas Behavioral Health Integration Network, a local nonprofit dedicated to better health for all through integration. Today we have project manager Caitlin Johnson and myself, peer specialist Megan Copeland, as your host. On today's episode, we will continue to explore the topic of postpartum mental health. We heard from our previous guest, Dr. Rogers, on his unique perspective from a pediatric practice. Today, we have the honor of talking with Dr. Nirvana Manning, who will share her valuable insights on this topic as an OBGYN and a member of the AMMRC, Arkansas Maternal Mortality Review Committee. We will get to that in just a moment, but we are a new podcast, so please remember to subscribe and share wherever you get your podcast. Also, feel free to drop us a note at www.abhinetwork.org for any feedback, questions, or episode suggestions. With that housekeeping done, let's get started with the episode.
I'm so excited to be talking about maternal health care again on our podcast. We had Dr. Rogers talk in part one about his approach to maternal mental health in his pediatric practice.
Which
And
is
he
going to
gave
be a
such
hard one to follow up on because it was such a great interview, right?
right. I think it really takes education and a little bit of humor that to deal with everything that comes with the population, because you've got two parents, the family members, and you've got the kiddo to take care of. So having a good balance, and I feel like he definitely brought that to the conversation and gave some really good real world suggestions. So
Absolutely.
yeah. But today's guest with Dr. Manning, I just am so impressed with her her view on how to make sustainable change in Arkansas, and the fact that she does like 4 different jobs, but the fact that she's practicing one-on-one with these patients, she's doing a lot of educational stuff within her health system, and then she's advocating at a state level. I think is what really is going to make such a big change here in Arkansas. So
I'm very impressed with her.
yeah. I kind of want to be her when I grow up. So knowledgeable about many different stuff, or many different things. And she gave us so many different topics to think about. And I think, one of the things that I took away from that conversation was just the access to care kind of drought that we have in Arkansas and in many states. And I guess I just didn't realize how many of our states are rural, and compared to Arkansas, with us having over 40% of our state being rural areas, and there being such a OBGYN desert, or just like a medical desert in general, in these
Absolutely.
areas. I just don't think I recognize that.
So, both of us live here in central Arkansas, so we have plenty of access to care anytime we need it. But, I grew up in Pocahontas, and I think I've mentioned that on the podcast before. So, whenever I had my oldest daughter, it was an hour to get to anywhere to deliver or to even visit an OBGYN. I think one came to town maybe once every month, and you could try to get an
Wow.
appointment with her when she was in town. But other than that, and talk about the fear of and the anxiety going into, I know that I'm going to eventually go into labor, and how am I going to get there in time? Am I going to get caught by a train on my
Right.
way there? Those kind of things. Especially, I was young when I had my first. I was 16 when I had her. So just the immaturity, and then also the anxiety and the lack of care and the lack of resources, and that place really made it 10 times worse than it had to be.
I can't even. I'm so glad that you mentioned the anxiety part of it, because I'm just thinking, as someone who hasn't had children, I just can't even imagine that big of a medical need, and like the best day of your life. You're about to have a child. You're very excited, and you have to make sure you plan out an hour and a half's worth of travel on top of getting everything ready to become a parent, and dealing with, I'm sure, the pain and the stress that comes with delivering a child. So, oh my goodness.
Now that I'm
Um,
thinking about that and I think about the experience of having my youngest, there were multiple false alarms with her. Like,
oh
I
wow.
I was close to being ready to deliver, and I would feel like I would be having contractions throughout the day. They were just normal to be having. It wasn't actually that I was in labor. But
Yeah.
if that would have happened when I was younger, I would have been driving an hour trying to get there each time that would be going. I think we went to the hospital like 3 times before we had Addie with these false labor pains. So
Oh my
you can
gosh.
imagine how, I mean, not only just trying to get an hour away, but also the financial burden that is on someone that may or
Yes.
may not be employed at the time, you know?
Exactly. Yeah. And I didn't realize that a lot of people deal with this. I mean, like March of Dimes was saying, like 7 million people in the United States deal with exactly that situation. And I just, you know, you kind of live in a bubble and you think only of your state really that you're living in. And you just think,
Mhm.
wow, 7 million people that are in that reproductive age window are also dealing with having to drive an hour, 2 hours, 150 miles just to get care. And you know, it doesn't mean that, you know, these 7 million people don't have any kind of healthcare in their area. I'm thinking my, you know, my hometown in Southwest Arkansas has a hospital, but there's no OB services. So
Right,
even if,
same purpose.
yeah, even if they do have that hospital, I mean, they would take care of you. They would make sure that, you know, like the emergency is triaged, but you don't even get to give birth in your own community. You have to go an hour or two, or, you know, like to, in that sense, Texarkana, and you may be giving birth in another state. So I just don't think I realized how big of a problem that was.
Yeah,
And
this
you
whole
bring,
experience and topic has been eye-opening and brings back a lot of memories for me too.
yeah, yeah. And I'm sure there's a lot of women out there that have very similar stories of just like the anxiety and the fear of like, am I going to get there in time? You know? And you bring up such a good point with the like money, the financial aspect, you know, and you think about these social determinants of health needs that come up with these appointments. I mean, you know, like you, like us being in a metro setting, I could like go on a lunch break, depending on
Right.
how, you know, how behind the doctor is. But yeah, I can go on a lunch break, get my appointment done, and come back to work and not have to use any PTO, not have to ask off for any time. But if you're driving like 150 miles one way, you've lost a
Mhm.
whole day worth of work. You got to use PTO that you may not have, or that you're saving for maternity leave, or
Right.
if you have any at all. Um, and that I just can't, like the stress that puts on a person's body. You know, we did a presentation. Aben did a presentation on social determinants of health, and within that series, there was discussion on social determinants of mental health and how chronic stress from things like, how am I going to pay the bills, how am I going to keep food on my table, how am I going to pay for my medical costs, create like long lasting health effects. So like if you've got this stress going on from 20 to 30 and it's resolved, you're financially stable, you've got, you know, the things figured out, you could still be dealing with that at like 60 or 70 years old, when your immune system's trying to fight off things that are a threat to your body.
Yep.
And because of that long-term exposure to chronic stress, it changes how your body reacted to those threats, and you're still dealing with it. So I'm just like, wow, you know, something as routine as just trying to get to a doctor's appointment, for like technically a specialty doctor's appointment, can create this like health issue, you know, 50 years later.
Yeah, and it doesn't end once the baby's born, because then you may
Mhm.
have a baby with jaundice that has to go in for light treatments, or you have those follow-up appointments more often in the first year of the baby's life than you do past the first year. So,
That is such a good point. I mean, you're going in like weekly at some points, even if there's everything's okay with the baby, right? Like, aren't you going in
well,
pretty
I mean, when
frequently?
Addie was born, she was jaundiced, so we would have to go up to Baptist, and I like I said, I live here in Central Arkansas, so it wasn't but like 15 minutes to the hospital, but daily. We did it daily for like a week.
Wow.
Mhm.
Oh my god. So like in that case, okay. So in that case, the mother would most likely end up having to stay in the hospital, like the baby, and at least the baby, and if not the mother as well, in a situation like that, which is going to
If your
create more
insurance
stress.
allows, usually after so many days, it's like, "Okay, you've reached your
Very
max,
true.
it's time to go home," so then it's on you to get back up to the hospital to get the treatment for your baby.
Oh my gosh. And then just I've treated mothers before that have had babies in like the NICU and that after right after birth, and just like being only 15 minutes away from that baby and still being able to go up every day is still so stressful and heartbreaking for them. I can't imagine for a mother to be 2 hours away from their child as they go through that.
Yeah,
Wow.
a lot to deal with at that time.
Mhm. And I mean, not even to mention how vulnerable the mother is at that time, right? Like all the hormones and
The hormone shift from after you
yeah.
have a baby is, like, so dramatic. I just remember sitting and just crying, like,
Oh
there's
man.
nothing anybody could do for me. Just
Yeah.
time and lots of prayer, just trying to make it through it.
Yeah. There's no clinical rhyme or reason. It's just our hormones trying to get
Shift,
back
it's a
into
big
balance.
shift, yeah.
Oh man. Um, and we're thinking about these obstacles, and I can only imagine that stigma is one of those obstacles, right?
Sure, yeah, I mean, you're gonna be worried that people are gonna be judging you if you can't get your baby the treatment they need because maybe you can't afford to go every day. Maybe you have to skip an appointment or
Yeah.
maybe you don't have that PTO like you said, or some people have to go back to work immediately because they don't even have maternity leave. So
Yep.
there's all kinds of obstacles and stressors during that time of a woman's life and on the husband too.
Yeah. I was just thinking, is like, what if you have multiple children, and and you are married, you do have a two-person household, and you do have a little bit of help for the other children, but like that's still stress on that unit, right?
We have officially talked you out of having kids ever.
I think there might be a such thing as too informed, because my goodness, I am very very aware of all the things that could go wrong. Oh man, yeah. And I don't know if that comes from just having well informed friends or just being in the line of work that we are. So
Probably a little bit of both. But man,
probably
it's
a
the
little bit of
best
both.
joy ever to be a mom. So don't ever let it completely jade you out of it.
That's what I've heard. I've heard that it's all worth it in the end. I
Mhm.
think my mother feels the same way. So
Depends on what day
I
you
think we
ask her.
do what?
Depends on the day that you ask her that.
That is absolutely true. That is absolutely true. I'll see how she feels about my attitude as a teenager these days.
Yeah.
Oh goodness. But not just, yeah, exactly. Like the stigma associated with not having the resources, and it's not even anything that you did. It's the circumstances of your
Mhm.
situation. But the stigma associated with like asking for help for your mental health, because we're talking about the stress and the pressure that's on you. Of course that's going to affect your mental health.
Mhm.
And I just, being in the position that I am, and then watching stuff play out on the media, and stuff like that, there's such a s- what's the word I'm looking for, negative view sometimes when it comes to women asking for help with their maternal mental health.
Definitely during that time, you feel like it's all concentration should be on the child and you sort of neglect
Yeah.
self
Mhm.
naturally. So just having number 1, feeling empowered to even ask those questions or having someone
Mhm.
else prompt you to answer those questions is key. And also realizing that you're not alone in this. Like I don't know
Right.
the exact statistic of women that deal with mental health issues after having a baby, but I'm sure that we're not the only ones out there going through this.
Yeah. Yeah, and we talked about with Dr. Rogers on how having a baby used to be a village effort, like a community effort, and you had your neighbors and you had your extended family, and especially in American culture, it's like independent. Like
Yeah.
independent is very valued in this culture, so that's really shifted, and you don't have the same support system, nor do you have the validation that came with that support system.
Absolutely,
of like,
especially
this
since
is
COVID.
normal.
I mean, people are just like,
Oh yeah.
"I'm gonna stay in my bubble and handle
Mm-hmm.
this on my own."
Mm-hmm. Mm-hmm. Yeah. And with the isolation, with the independence that is fostered here, the idea of, if I reach out for help, people are going to think I'm a bad parent, right? It goes along with, no one else is dealing with this, I'm the only one who's dealt with this before, and I'm a bad parent for even feeling like I need help or a break from my children.
Right. And then also I don't know about others, but for me, that was a transition time in my life. I had used drugs and alcohol for
Hmm.
most of my teen years. So I was paranoid naturally, thinking,
Yeah.
oh God, if I don't have everything together, someone might take my baby away from me. Or, you
Mm-hmm.
know, afraid to even be vulnerable to open up that can of worms.
Oh yeah. Oh yeah. Great point. And it, especially in that sense, in that realm of, the substance use disorder, you're just trying to figure out what your body's asking you, what your brain's asking you. You're dealing with, past trauma, and dealing with your own mental health stuff that predated having this child, and then on top of it, now dealing with, I'm a new mother, I kind of, I sometimes don't know what I'm doing, I need help and I'm afraid to ask for it. And then again, like you said, the extra layer of like, if they find out that I have this other health concern, are they automatically going to assume I'm a bad parent and take my
Mhm.
child, and I'm going to lose them forever? And it's almost like, I'd rather sit and suffer than lose my child. And like you
Yeah.
said, you put yourself on the back burner. But I also, so you've got the public stigma, right? So, and I don't think we would be lying at all if we said there are people out there that do think that, like, people that come out and ask for help during maternal, the maternal, or the perinatal period rather, are like, not good parents, or they just need to be a little bit stronger. And that's that like stigma that is perpetuated through like Lifetime movies, and
Sure.
through these stories that you see on the news. And there are situations where, postpartum psychosis is very real. Postpartum depression and suicidality and postpartum anxiety are very, very real problems. But most of the time, the situation is not escalated to what you see on the news, right? It's
Right.
just these parents are suffering in silence and by themselves, and it never gets to that point, but it still affects how they view their experience with motherhood and how they interact with their child, and it just puts a negative connotation on some of those experiences.
The world definitely, everybody could just lend a little more empathy in general. I mean, just kind of having some understanding that not everybody goes through the process in the same way, and that we're most of us are doing the best we can with the situation. So, just I
Hmm.
think everybody, if they were just a little more empathetic, it would go a long way.
A lot more grace, yeah. Kind of like I said, you and I were talking before we jumped on here about how everyone has an idea of how they'll parent their kids until they have kids, right? It changes once you're actually in the sauce, so to speak.
Yeah.
So I think too is like, we all have these mentalities of like how we would do it differently if we were in that situation. And you're not in that situation, and it's a privileged view sometimes to say, oh, well, this is how I would deal with that, even though I've never experienced that stress.
Yep.
Yeah.
So I know, and this is kind of a funny story. I know that like when I was pregnant with Addie, I wanted all of her baby stuff to be neutral colors. Not
Hmm.
because I didn't know that she was going to be a girl. I just thought that was beautiful. And like as time went on, I got more and more lax that we had more Mickey Mouse and princesses and all the things, you know what I mean?
Yeah.
And I think it's like that with our healthcare as well. We go into it thinking, oh, we're going to be super focused and we're going to make sure that we're
Yeah.
checking all the boxes and making lists to talk to the doctor about all of our concerns. But then when you're in the moment, it all becomes a little more than you thought it would be. And we get a little more laxed in that situation. And it ends up, you don't quite meet the standard that you thought you were going to meet.
Yeah. Yeah, and it's oh, that's, I love that comparison. I love that, is such a good point to bring up. I just was talking to my husband about my therapy appointment yesterday, and he just asked how it went, and I said, yeah, I went in with one thing, with one topic I wanted to talk about, and we talked about something completely different, and it was helpful, but it was just to your point, is like you go in with the best laid plans, and you go
Yep,
in with these lists that you think that you need to work on, and then something overtakes the appointment, or something like an emergency happens or whatever it is, and you just don't get to it, and it falls to the wayside, and it's often you as the mother that ends up falling to the wayside, you
that's
know.
right.
So that's a great point. Great point. So, you know, the stigma, the public stigma, and then the internalized stigma can really prevent someone and discourage someone from even reaching out to their support system, whether that is like their neighbor or their sister or their healthcare professional. And in these like desert areas, that healthcare professional is often the mother's primary care physician because they don't have access to that OBGYN. And healthcare's gotten better with the technological advances and the medical advances. We're able to, I'm able to email my doctor anytime I want, or maybe jump on a telehealth call depending on what the issue is. But there's still a significant lack of services. So often the mothers are turning to their primary care physicians, as they should, for help
Hmm.
with some of the things that are going on. And I can imagine that there's even a fear of talking to this PCP, even though you've probably seen them for years, especially in a small town. You're most likely going to keep going to the same primary
Right.
care doctor because what is the other option, right?
There may only be a couple in town anyway.
Yeah. Yes, you're going to see your PCP on Thursday, and you'll see him at church on Sunday as well.
That's right.
But I imagine there's got to be some kind of fear, right, with even bringing it up to the PCP of like, what if this person who I've trusted for years thinks I'm a bad person or a bad
Mhm.
parent for bringing this up? Are they going to automatically assume that because I've got postpartum depression, I can't sleep, whatever it is? Do they think I'm going to be a bad parent and they're going to call whoever, and it's going to result in me losing my child?
Yep, and just think of, the public stigma too there is like, so you see them everywhere you go. It's a small town, everybody knows
Yeah.
everybody. So, like, you don't really have an option to go see a different doctor if you do become uncomfortable. You're just kind of there. So you're really
Right.
trying to put your best foot forward and make everybody think that you're fine and everything's good.
That is such a good point. Yes, yes. And then, like, okay, if you bring it up, your treatment choices are not usually the best. Like your choices are going to be, especially in a small town. Okay, here's a possibility of an antidepressant, and I know with being pregnant, you're severely limited on what you can be on, if anything. And then once you are postpartum, it's still limited because you might be breastfeeding, and there's such a small opportunity for treatment, especially being in a small town. Who knows if there's going to be a therapy option for you, and there might be a community mental health center you can go to, but it may be 3 months before you can get in, or something like that. So it's like, even if I bring it up, what do I do? And I can just imagine that running through a lot of women's heads of like, what's the point of bringing it up, because
Well, it's
I don't have any
probably the
options.
same for the doctors as well,
Yeah.
especially if they're, like, understaffed and don't have that
Hmm.
integrated healthcare model in place already. So, if they're doing these screenings and someone's coming back with results that implicate that someone does have mental health concerns, what do they
Hmm.
do with that? Okay, so now we know there's a concern, but we don't
Right.
have the resources to do anything about it. So, it's probably like, why even do it if you don't have the resources? But
Right.
like you said, there's so much today in advances technologically in ways that we can connect with therapists through Zoom meetings or, like you said, telehealth, and then also peer recovery specialists in the area. I
Yeah.
know that most counties now have a peer in the area. So if someone does have a substance abuse or mental health issue, you could always reach out to a peer in your area to kind of have a mentor in their life. While they won't provide any kind of therapeutic sessions or anything like that, they can help guide them in resources.
Right. Well, just having someone there who has been through what they're going through is therapeutic in itself, right? Just having
Absolutely.
that fellowship there is, and again, to your point earlier in the conversation, just knowing that I'm not alone, that this is a normal emotion to feel. And this is freaking difficult. This is hard.
For anyone.
And I understand why you're struggling with it. But yes, you bring up such a good point. And, of course, we're the Arkansas Behavioral Health Integration Network. So we're going to bring up integrated health. But like, how many rural clinics can afford that, right? Like, not many of them are going to be able to afford an LCSW or a PhD or an LPC
Right.
to be in their clinic. So it's like, okay, there's an opportunity to collaborate with the community mental health center for sure. I've seen that done. But I love that fact that you were like, bring in your community, like community options, your resources out there, especially with your peers. Don't think you have to do it by yourself. Reach out, make a connection with those peers. And I know there's that website. You remind me what it is, where you can look up your peers.
arpeers.org.
Right, where you can look at, I mean, by your county, and clinics that are listening to this conversation and looking for education and ways to help their patient population, go on there, look up your county, see who is in the area to help with these types of conversations, because not only is pregnancy scary, I'm sure, for a primary care physician to treat, but also substance use disorder, that comorbidity there.
Yes.
So I can imagine that's very stressful for them as well. So I'm so glad you brought that up. There's some other ways too. Integrated health can look like whatever you need it to look like. Yes, there are models out there that we follow, especially if you've got somebody embedded. But again, that's not an option for everyone. So integrated health can look like, using these screeners routinely. The Edinburgh postpartum depression screener is out there, and used frequently to identify people who have just given birth and are maybe experiencing that depression. They could be coming in for just their annual checkup. And if especially in a small town, know that they just gave birth not too long ago, screening those people, not just waiting for them to come up and say something, because just like the stigma we talked about, they're more
They may
often
never
times
even
than
bring it
not.
up.
Yeah, they're not even going to bring it up, most likely. So that's the first line of defense, is screening, and you bringing up the topic makes it known to them that you are not judging them and that you just want to help.
Yes.
Another option is just educating your staff. Most places aren't going to have a social worker on staff, but what they are going to have? A nurse, an
Yes.
MA, oftentimes a care coordinator, depending on what kind of program you're involved in. And those are people on that staff that can learn brief interventions within their scope of practice. They can learn motivational interviewing. They can learn behavioral activation about normal stuff, sleep hygiene. Of course, new mothers aren't going to be sleeping. How can we make the sleep that they do get as good as they can? The 2 or 3 hours you're getting. And then, how do we make sure that you're still exercising, in a way that's safe for you and that keeps you healthy? How do we make sure you're getting nutritious food in you and you're not just scarfing down an Uncrustable because you're running in between between meetings and taking care of a child and all of that. So, these are things that your staff can learn and can be done in 15 minutes, and just sitting with the patient after they've been identified and saying, hey, I know you're struggling. Let's come up with a plan together. Let's do some SMART goals together. And that's what integration can look like for you. So there's opportunity just in education, and then just sitting and listening to your patients.
Love that. I love that you shared all those options for people that do not have the financial means to staff someone.
Mm-hmm. And I'm thinking, Dr. Manning talks about this in her interview, about how we make sustainable change, and it is crucial for us to have these important conversations one-on-one with our patients, for sure. But it's also important to change the system delivery, so that we don't have to continue having these conversations, right? So it's like the starfish story of, like, you're making a change if you're walking along the beach and you pick up one starfish out of 1,000 and you throw it back into the ocean. You made a difference in that starfish's life. But I think we
Mhm.
also need to figure out why all these starfishes are
On
coming
the
up onto
beach.
the beach. Like, we need to know why this is happening, so we don't have to have us throwing them back into the ocean all the time.
Yes.
And Dr. Manning takes such a unique perspective and talks about it in this interview, about how she takes her real live experiences and uses them to advocate with our legislature and with our medical leadership in our state. And I think that's
Those types of
just so
testimonials make
crucial.
the biggest impact. So
Yeah.
I'm so grateful that we have her representing us here in the state of
Hmm.
Arkansas.
Hmm. Dr. Manning, we are so excited to have you on today's episode. Do you mind introducing yourself? Tell us a little bit about Dr. Manning.
Sure. Well, thank you guys so much for having me. My name is Nirvana Manning. I am an OBGYN by trade. I also serve as the chairman of the Department of Obstetrics and Gynecology at UAMS, as well as the Women's Health Service Line Director. Um, Tell us a little bit about yourself. Well, I have three children, one of which is about to become a senior, so I'm dealing with all of the big emotions that go along with it. I think one of the questions was my hobbies, and I am like an old soul and love like reading and puzzles. And so that is where I spend a lot of my free time,
I
besides
Love it.
all my children's sporting events. Yes.
Oh my goodness, I imagine. I mean, the hobbies, it sounds like you're so on the go that your hobbies probably need to be something a little bit low key.
Oh, mindless. I love like just mindless. You can put in like a book on tape or listening to a podcast and do puzzles. It's beautifully mindless.
Yeah. So like I said, you sound pretty busy. You got a lot of hats that you wear. What brought you to this profession? What said, in your life said, let me go into OBGYN practice. What led you
Oh.
to this?
Well, in med school, I feel like a lot of my family members thought I was going to go into this field. And I think it almost made me not want to do it. But in the end, I love the opportunity to take care of women in such vulnerable situations, like to be a part of these really private, intimate moments that are just A, extremely joyous in some situations, and B, just devastating in others. And the fact that they kind of invite you in to be a part of their lives and their families during these kind of really life-changing times, I think is so amazing. And I love just taking care of women throughout the whole aspects of it. And I think as I've had a daughter more recently, that puberty adolescent part of it has really driven me as well.
Yeah, I was doing some research for this episode, and I did get the sense that it really takes a special person to be able to navigate these life instances, like you said, these life changes. I mean, you're seeing people that are going through huge changes in their lives, and for you to be there during their most vulnerable moments, whether it is joyous or it is not, is takes a special person. So it sounds like you've really got to have some passion for this, and it sounds like you do. So
Yeah, no, I absolutely love it. I just most recently getting into some of this advocacy stuff has just been very eye opening. Like, I love my day job. I love taking care of patients in the clinic. And it was a mentor of mine many years ago that was just kind of mentioned, like, in a clinic, you can take care of one patient at a time. But in this arena, you can kind of help thousands with some, you know, um, and I'd never really kind of put that to words and to action until more recently, when I've been given the opportunity to do some of this stuff, and I can it's definitely fills my cup.
I like that. I like that. The advocacy work that comes with this type of practice is so unique as well. And you're like you said, you can help someone in your clinic, kind of like the starfish
Right.
story, where you're throwing one starfish back in the ocean, but really asking, you're going above and asking, why are the starfish coming out of the ocean anyways? Like, why is this happening anyways? And I think taking and giving your patient a voice in a space that maybe they would not have had at a higher level, at a state level or at a national level, is such a brave thing to do. So I'm so glad that you're involved in that advocacy. I think you have a very unique perspective that you bring to that. I'm really interested in your role in preventing maternal deaths, and some of that may come very like um, people may say, well, of course she has a role in preventing maternal death. She's a doctor. But let's talk a little bit more in depth to what that looks like for you, and how that affects mental health, relates to mental health.
Sure. So obviously it comes organically just from my position. As an OBGYN, we have two patients. Quite often we have the mom and the fetus. And so sometimes it becomes a very teetering act, making sure we're getting that baby as far enough along as we can while not jeopardizing that mother's health as well. And so we navigate that line a lot. I did my residency here in Arkansas in Little Rock at the University at UAMS, and it's the only tertiary care center in the state. And so with that was given the opportunity to really take care of the sickest people. And those terrible situations stay with you. They stay with the physicians for sure, but they stay with those families even more, and they stay with that community. And I think seeing what that ripple effect does is just astonishing, in a terrible way. And so every maternal death is obviously an enormous tragedy, but what we don't have a good quantifiable number for is the morbidity that goes along with that. And there's estimates with regards to, 10 for every to 50 for every maternal death. There is women that suffer severe maternal morbidity that's just essentially life-changing events that have changed the course of their life at that point. And so when you think about that on a statewide level and what it's doing to our patients, their families, their communities, the workforce, the economic impact of that, I mean, it's huge. And so, we were, the legislative body in 2019 voted for us to have the first Arkansas Maternal Mortality Review Committee, which is amazing. So it gives us quantifiable data that we can now look at and be able to compare to surrounding states, to other areas. How are we doing? How is it looking here? Because we are unique. Arkansas is not like it is in Idaho or New York. And so how can we better use the data from our state to make it safer for moms and families to have children and prosper? And so I had the opportunity to be on this committee from its fruition. So that in and of itself has been so eye-opening. And I think we'll talk about that hopefully a little bit later as well.
Yeah, I actually am. What a fantastic point at the fact that a maternal death does not just affect the family and the family unit, but it affects the community and it affects the workforce and the economy. I don't think I've ever even considered it that way. So that's a very good point. And like you said, we'll get into the committee information a little bit further down, which now I'm even more excited to talk about. But I want to dig a little bit deeper into the comorbidities that happen during the perinatal period, and then all the way up to the 1 year postpartum period. As far as mental health,
Yeah.
what risks are you seeing mothers dealing with during this period? What's a high risk possibility for them?
So I think I'm going to back up. I'm going to answer your question, but just back up for just a second. So one of the things that we were able to see in this Arkansas Maternal Mortality Review Committee is kind of when are these maternal deaths happening, right?
Mm-hmm.
And so we'll talk about things like 92% of them being preventable. And that's a huge number,
Wow.
right? But that falls under, and we look at from birth to 365 days. And so in that number, we include suicides. We include overdoses, because I would hope on some level those could have been preventable. We include a huge myriad of things into that. And so in this committee, we talk about every one of those maternal deaths at length. And one of the things that we saw is they kind of fit into three buckets. And one of which is right around that immediate hospital stay, delivery, and the immediate postpartum period before they go home. The next bucket of things kind of fell into like day 1 going home to about day 45. And there is a myriad of things that go into that, which is some of the cardiovascular things and some of the sepsis and infection and bleeding. And then the last bucket was that 45 days to 365 days. And this is where our mental health and substance use disorders really fell into play. So it is not to be underestimated in that it is 1/3 of the the things that are affecting kind of our patients and families. And I'd be remiss to say that it didn't get worse with COVID. I mean, as we see in all things related to life, things became harder. People became more
Yeah.
isolated. There's more constraints on finances. There's less family units that are available. And these were all things that helped these moms in these postpartum periods that now some of those foundations are not there. Substance use disorder is an all-time high, whereas, our mental health providers, there's not nearly enough in our state to kind of tackle this issue. And so it kind of snowballs on itself, and postpartum is just such a vulnerable time for so many of our moms and families that it just succumbs to that.
So you bring up a good point with COVID and how, yes, we, and being a mental health clinician myself, yes, I definitely have seen an increase in substance use disorder in the patient population that I was seeing in primary care for sure. I think there's a little bit of a subsection too of these mothers that experienced the trauma of loss during COVID too, and like the loss of a routine, a loss of even a job or a family member to COVID. So adding grief onto of several different losses on top of having to navigate a pregnancy and bringing a child into the world, it just is so taxing. I can't even
Yeah.
imagine how difficult that is for someone to navigate, especially if they do not have the healthcare needed to do so.
They don't have, yes, I agree. And, over 50% of all of the births in our state are covered by Medicaid. Um, and that coverage ends at 60 days postpartum right now. And so not only all of these stressors, but they also don't have the insurance or the coverage aspects in order to um, continue care or even get care when they need it. So there's a lot of work being done in this space. Governor Sanders did an executive order such that women that may lose coverage, we're going to take extra efforts in getting them in coverage that's available throughout the state. If there's not coverage, we're going to see about ways that Medicaid may be able to bridge some of those gaps. So I know there's a lot of work being done, but today, right now, if you don't have insurance or a private insurance option, that Medicaid coverage ends at 60 days.
Wow, that's crazy. And I did not know that information. All this whole conversation has been very enlightening to me. Number one, because as a peer specialist, the substance use disorder piece plays into my everyday life. So hearing that that is taken into consideration in maternal health is very important to me. And then I also have a daughter that is currently pregnant. So hearing and knowing the mental health struggles that she has
Yeah.
had throughout her life, that is taken into consideration is also impactful to me. So I would just really appreciate you sharing those pieces. I want to back up just a little bit because you had mentioned you have been on the AMMRC committee since its inception, and I wanted to know what motivated you to serve in this committee.
Well, I just felt like it bridged a lot of gaps. I am so fortunate to be invited to so many different tables these days. And some of it falls with my roles at UAMS. I think some of it rolls under other advocacy things that I'm doing. And so being able to have firsthand knowledge of some of that information definitely can tie into other areas. And I think sometimes it just takes those stories. I mean, we resonate with stories. We sometimes the statistics, though very compelling, get glossed over, but those stories, it's hard to not remember those. And so when I'm talking to a legislator or when I'm talking to a different advocacy group, it's so important, I think, to remember some of those stories. And I love that I'm able to have a account of what happens in this committee so that I can go. I mean, we can't invite everyone to this committee, though I would love for people to get a glimpse into what happens there, but it at least offers a firsthand account of what we do through each of these maternal deaths and how in depth we go into things that could potentially play into the preventability piece of this and be able to come up with some really poignant and hopefully actionable pieces to take away from that.
Mm-hmm.
So the trends that you're seeing in Arkansas, there's a committee like this in every state, right, Dr.
Most
Manning?
states have them. I know we were one of the last, and I don't remember if ever. Most states have them. Don't hold me to everyone, but most states have them.
Absolutely. Do y'all get to see the broader picture of the nation as a whole, and how does Arkansas compare to the other states and
Sure.
the different work that they're doing in each state?
So, the number, the N, though tragic, is relatively small. So, right, it's 30 to 40 maternal deaths out of about the 35,000 that we have in births a year. So those numbers, when incorporated with other surrounding states or with multiple years, obviously have much more impact. And so that's where we're able to see trends. When we compare ourselves with Mississippi, Louisiana, Alabama, very similar rural southern states that have a lot of the same constraints that we do, we're able to see, okay, well, cardiovascular disease is much more prevalent in this area than it may be in the Midwest or in the Western states. And so those are things that we can take home and then hopefully do more global education in these areas and target some of the resources that we have towards prevention and obesity and chronic hypertension, and really be able to say, okay, in these states, here's where we can make a really big difference. Whereas it's very different in some of the other states that don't have the same constraints. So I do think it helps to have several years, but all of that data is collaborated and it sits under a national organization called Maria, and they will, we feed that data to them, and then they give it back kind of in much more readable forms. But that's what we use ultimately to create. Dr. Sam Greenfield is the chair of that committee. He's also in my department. So he sits 50% in the Arkansas Department of Health and the other 50% at UAMS in the Department of Obstetrics and Gynecology. And so having him bridge those two areas has been so helpful. But he uses that data to then create his annual report that really gives each person kind of some take homes, whether it be an individual, whether it be physicians, a hospital system, community organizations, legislative groups. Like, it kind of gives everybody, here's where you could help, and this is where it could make a difference.
Love that.
I do have a question. We asked Dr. Rogers a similar question, and I kind of want to get what your take is on it too, Dr. Manning. He told us that you guys meet. Is it quarterly?
Usually
with this
4
committee?
times a year.
Okay. Okay, and it's a day long session, right? So these, with the job that you, just multiple jobs that you have now, and the being on the committee, you deal with a lot of heavy stuff, like, for lack of a better phrase,
Yeah.
heavy stuff, and especially sitting an entire day just reviewing maternal deaths. How are you taking care of yourself in that space? Like, how as a clinician, and I'm sure other doctors are going to be very interested to hear that, because I mean, that's so
It
heavy.
is, and I mean, I'd be remiss to say it doesn't affect your daily life. I think it makes you super thankful for what you have. I think it also gives such perspective into what my patients are dealing with on a day-to-day basis. I have no doubt it makes me a better physician when I walk into that room. And when we look at things like, African American women are dying at a greater rate, and if I have a patient come in, it has to play into that. I have to look at things a little bit differently and say, what could I be missing here? And I hope that's where we all are, and we take that into our communities and into our hospitals, and we talk about things in different ways, and not necessarily just look at the statistics, but looking at the patients that are behind the statistics, I think is what's going to make a big difference.
Mm-hmm. Mm-hmm. So hearing gratitude is one, and then making sure that you're not just looking at the number, not just looking at the outcome, but also remembering that these are our neighbors, these are real Arkansans that this has gone on with, and these are real families here, and taking it and letting it influence your practice. I love that. This committee categorizes deaths as preventable versus non-preventable, with a vast majority of them being preventable. So when we're looking at deaths with a mental health factor, what are some of the preventable things that are most common in those situations?
So, I mean, I would think in the, like I kind of said, it falls into that mainly second and third bucket. The first bucket being kind of that immediate hospital stay. And those are things like, hemorrhage, sepsis, some of the urgent, emergent things that can happen, the cardiovascular, the MIs, the strokes. Then the second part of it, and bleeding into the majority being into that third bucket, is the mental health. Do they have pre-existing mental health concerns? Were we able to address that? Did we have access to address that? Did they live in an area that there was providers to address that? Did they have insurance coverage to assess that? And then, did we have them on medication? Did we address that in the postpartum period? Representative Pilkington just passed a law, I guess you could say, that now we have to do the postpartum screening on every woman in the immediate postpartum period, which is wonderful that we're screening. But now it puts a lot of people in binds where, what do you do with this information when there's not necessarily providers in these areas to do that? And so it puts physicians in a very tough situation. I was talking to a friend of mine that works in in a very rural state, and she says, I see this, but I don't know what the best way is, and I don't have the bandwidth nor the expertise to do it. A lot of times insurance won't cover it. And so where are we now with regards to that? And how can we expand that? I mean, Caitlin, you mentioned you're in this field. How can we create incentives for more people to go into this field? I don't think we'll ever not need people in this field. And how can we help support you guys more? Because like you mentioned, the MMRC is heavy. This is heavy. You're dealing with not only this one issue, but a myriad of other people's issues. And so I think people get burnt out. And so I just think as a state, we are going to have to commit ourselves to seeing how we can help sustain a continuous pipeline of people going into these fields that may not be necessarily glamorous or super lucrative, but are so needed in our communities for our just fellow Arkansans.
Yeah. No, a great point there. We actually on that mental health work group at the Capitol, that has been a pretty frequent question of how, exactly to your point. And I've heard many doctors ask me the same thing of, if I'm screening for something like depression and I don't have a resource to send my patient to, am I doing good? Am I still doing the right thing by asking the question and not having anything to give that patient? And the question came up of, how do we increase mental health clinicians in Arkansas? And the idea of loan repayment came up, which is always a fantastic idea for anyone in any profession. School is expensive, right? But burnout, such a good point on that, is burnout. This is a heavy subject to be talking about every single day, and I think that comes from education in our schools, right? The curriculum should include some capacity of, how do you recognize burnout, and how do you keep yourself from burning out? How do you lean on your community resources and your own care team? How do you do those things? So really good point. One of the things, and I'm kind of skipping around here because I do have a question that leads into this. you mentioned that Governor Sanders is bringing up that initiative to help mothers especially with increasing insurance coverage. And your question is basically my question: how, if we increase coverage and thus increasing access, how do we increase competency in our healthcare workers? So it's not necessarily that we need every single person to be a licensed mental health clinician and a medical doctor. Like we don't need that to happen. What we do need is some education on in all specialties to know how to talk to someone who is in crisis. So I'm wondering, in your practice, how do you identify someone that is in crisis? What do you listen for? Do you use specific tools? I'm sure some of our listeners will be curious on how are you listening for these
Sure. And
things?
I'll say, I mean, again, I'm very fortunate that I work at a tertiary care center in a metropolis kind of area or a large urban area that has a lot of resources. So, I mean, we certainly use our questionnaires. We meet with our postpartum moms. We talk about it immediately in the postpartum period during their hospital stay if they have a history of it, and kind of warn them of some of the warning signs of what could be coming down the pipeway. We also talk to those significant others because sometimes the patient themselves don't see themselves spiraling, but those loved ones around us do. And so equipping them with numbers to call, our number, in addition to, kind of our hotlines and numbers that can help direct care if we need it, and then where to go if it gets really bad. I mean, if we are really bad, dark place, or you see that loved one in a really bad, dark place, what do you do immediately? And I think equipping them with some of that knowledge. Now, you go into our more rural states, and those are all within their same kind of, they don't have separate people for that. They serve all of those roles. And so I think some of the work we're doing, we are teaching ER physicians and groups. Most of our counties have some sort of access to an emergency department. And so, how can we, through simulations, through different protocol driven things, kind of use algorithms to help direct where that patient should go and what the best way to kind of stabilize that patient is? It's very similar to some of the things that we're doing with kind of that first bucket I talked about, where some of those big bad emergencies, if those are never events, we don't expect to see those very often. And so in communities that deliver like 200 to 300 babies a year, they may not see some of these events for 2 to 3 years. Well, how do you keep yourself well versed on things that you don't see frequently? And it's through simulations. It's
Mm-hmm.
through creating toolboxes so that you don't have to think then and now, oh my gosh, what to do. You open your toolbox, for lack of a better word, and that algorithm takes you and through that. What's the standard of care for that?
A very unique take on that was involving the family. I don't think I've heard that before. If not, you've got the idea of the screeners, and you've got the idea, kind of the safety net, so to speak, for that. But there's a stigma associated, especially during this period of a woman's life, that that you should have it all together, that you're the adult, and you don't want anyone not to trust you. So it's really scary, to be honest, on some of these screeners. So
Yeah.
making sure you check in with the loved one that's coming to the appointments, or maybe as a contact for them, that's a great idea, to make sure that that you've got multiple
Yeah.
points of
No.
contact for
I think
these
that's huge. And
patients.
I mean, again,
Yeah.
personally, I have 3 kids. I'd be, I mean, I was not well. And so it was the people around me that could tell me that, because you're so upside down in just kind of the day to day and just exhaustion that you may not know. And you may not even know that it's abnormal that you're feeling this. And so it takes a village, for lack of a better word. And if you don't have that village, we have to fill in that village around you.
Yes, absolutely. Like you said, we may not have that village. Your village may be your
Yeah,
care team, and making sure that they are ready and comfortable with having that
absolutely.
conversation and willing to have the
Yep,
conversation, right?
absolutely.
Um, One other thing I did want to point out is is using the algorithm. And when I think of that, I think EHRs, using your EHR to the capacity, like its full capacity, having those conversations, if you can have them with the developers. I know with Epic, they typically have a team that you can talk to about that kind of stuff. Maybe there is a specific build you need to utilize, but leaning on the EHR to also have, like, using the tools that are available to us, to set up some of these algorithms and these workflows. So if the human isn't catching it, sometimes the system is
Yep.
catching it,
Yep.
right? One more question, then I'll hand it over to Megan. Creating the toolboxes and simulations, love that. Is there a organization or a speaker that you typically, suggest to people who are looking for this type of
So
education?
there are, and again, luckily we're not reinventing the wheel here. And so about 2 years ago, we became something called an AIM state, and that stands for the Alliance for Innovation in Maternal Health. And by becoming an AIM state, we agreed to kind of adopt these California collaborative bundles of healthcare. These are not new. We're not starting this. California started these 10 to 15 years ago, saw dramatic improvements in maternal morbidity as well as maternal mortality. And basically, it's just like that. It's a protocol driven. It says any person in this care team can start the process. So for something like chronic
Mm.
hypertension and they come in with severe range blood pressures, you don't have to wait for the doctor. If they come in with this, you start it right here. And anyone on this care team can start it because the algorithm kind of speaks for itself. And so
Mhm.
there are bundles for a lot of these things. And so we have now adopted those. We are now going into all of our delivering hospitals around the state, which we have 35 of, and reinforcing what that looks like so that they have those tools, those toolkits that they can start that algorithm as well. And then we're going to gather that data. And that's the Perinatal Quality Collaborative that we've created under that AIM umbrella, is collaborating all that data just with regards to Arkansas and the hospitals that we have in our state, and seeing what our data is. And that way we can better, and this is not a finger pointing, this is a let's build each other up and let's see where some of our, you know, areas of improvement could be. What are some, okay, maybe this area has not really adopted this bundle. Tell me why. And let's talk through what these things are. Is it personnel? Is it lack of education? Is it a myriad of other things? And then we can address those specifically. But until we kind of get data, we are right now just broadly kind of helping everyone make sure that they know what the bundles of healthcare are, and then being able to adopt those within their own institutions.
Great. And as you went in to say about, this isn't finger pointing, I was just thinking to myself, this is really
Mm-hmm.
motivating. Like, this is very uplifting because, as clinicians and peer specialists, we hear kind of the bad part of what's happening. Like, we get the brunt of the bad stuff, but to hear, like, yes, this stuff is happening, but also we have solutions and we're
Yeah.
ready to work with you on it, and we're
Absolutely.
motivated,
And
is so
I
encouraging.
think
I'm
it
so
takes
happy
some
to
of the
hear.
pressure off of the providers. I mean, again, if
Oh,
you've not
yeah.
seen this and to be expected to know what to do in an emergency situation where we know that minutes matter, I mean, gosh, that is very overwhelming and scary. And again, I need providers in our states. I don't need them scared and to go away. So this helps kind of bridge that gap so that they don't feel like they're out on an island by themselves.
Yes. Yes, that it's a safe place to ask
Yes.
these questions. Yeah.
So I'm just going to follow up with this to ask you about if you could describe what the intervention workflow would look like within your own practice,
Okay.
using some of those screeners and maybe a case example that you could give us.
Sure. So, I guess we could start. I mean, the intervention workflow. If we aimed it with maternal health, like let's just say maternal mental health. Say
Mhm.
I have a patient that presents at 15 weeks with a new OB visit, feeling extremely overwhelmed, um, anxious, may not have even had a history of mental health illness or um, medications in the past. So we go through a questionnaire, kind of where she is now, and then we have the opportunity to have some women's mental health providers that we practice really closely with. So that's a really lucky resource that we have, and they are incredible. So they will then use physicians as well as therapists to kind of help surround that patient with whatever resources they need. It may be medication, it may be therapy. We follow them through their entire pregnancy. And then in the postpartum period, we circle back to all of these things because though, you know, things can certainly change throughout that pregnancy and postpartum period, but things may improve. We may be breastfeeding. There may be other elements that come into play with regards to some of that. And so ideally, we have now created a network for them that they can then piggyback on, hopefully, for years and years to come. And I try to, reinforce with patients, like one of my favorite things to say to patients is talking to someone that doesn't love you is so helpful sometimes. We surround
Yes,
ourselves with people
absolutely.
that love us and they want to fix us. My husband doesn't want to see me upset or sad. So sometimes you don't want to lay that all out because you don't want them to take on that burden. But talking to someone that doesn't love you, that's a neutral party in this, and their goal is just to get you in a better place, it's priceless for a lot of patients. So sometimes putting in that perspective is much more engaging.
100% agree with that. So, for listeners that are non-clinical and in the community setting, what would you like them to know about supporting the mental health and well-being of mothers in their community?
Yeah. I would say listen to them and just look at the nonverbal things as well. If it's so easy these days to judge and make very rash, kind of quick judgments on people. Um, Everyone's struggle is very, very different. And so I think meet people where they are as much as you can. If you see that a patient is continuously, from my standpoint, if they're continuously late to appointments and they're having trouble and they have kids with them, there is likely something else going on in this. And so don't kind of blow this off with regards to they're just non-compliant and I think ask about other resources that they have. Their church environment may be a huge resource to them that they have not encountered, or, different groups within their communities. I mean, I think this is where our community healthcare workers can also help navigate that pregnancy, but really that postpartum period in such a different aspect. Um, it could be food insecurities. It could be transportation issues. There could be so many things playing into this woman's mental health as well as what's happening in that immediate postpartum area. That I think just listen for the nonverbal cues.
In addition to Megan's question, um, we see there are some, like I said, there's some stigmatizing language or behaviors that happen in the community as well. Can you speak to some of the stigma that you find trying to get mothers to talk about these situations, and how we can change maybe our language or how we approach these situations with mothers?
Well, so more with regards to the stigma with regards to it, is that what you're asking?
Yeah.
I have found, so I've now been practicing, oh gosh, close to 17, 18 years. Um, we have
Mhm.
improved so much in healthcare with regards to talking about this. I mean, this is something we barely tapped into at the beginning of my career, and it has now taken on kind of a much bigger um, needed portion of each visit. In addition, I mean, especially in that immediate postpartum period. So kudos to everyone that is talking about this. Kudos to, bringing this up and making it less of a stigma to talk about. I still think there's obviously work to be done, and people and women feel less than when they don't have it all together. And I think a large part of that is probably our social media and how we portray mothers, that they have it all together. And though they are super women in so many things, they are juggling most of the time everything in the household, in addition to the unpaid work, in addition to the jobs, and then taking this on. So I think having grace, and really making sure you are discussing it with them, whether it be your sister, your mother, your child, kind of making sure they're doing okay in this pregnancy and the immediate postpartum period. But I just think we have to keep talking about it.
I'm so glad you said it that way, because in our recording with Dr. Rogers, we said the same thing. Actually, as it's a lot of social media and media in general portrayal. These sitcoms that have moms running around and doing everything at one time. That I mean, and people just not knowing postpartum is really not supposed to be like that. You're not supposed to be able to do everything. That is an unrealistic standard. It's okay to need help.
Yes.
And
Life
sometimes our
isn't
social media.
always picture perfect.
No. And I said,
Yeah.
after having my first, I could not say more. Like, it is okay to ask for help. It is expected to ask for help. Like, you should not have to burden this all on your own. And people want to help. Sometimes they just don't know how. And so being much more secure in yourself and saying, here's what I need. I need you to do laundry. I need you to come over to my house and literally just watch this kid while I sleep for just a few seconds.
So, Dr. Manning, what do you hope to see happen in the postpartum care space in the next 5 to 10 years?
So in the postpartum care space, I hope to see a ton more community healthcare workers implanted all throughout our state. I would like for every delivering family to be paired up with someone to help navigate that postpartum period and whatever comes with it. And that could be, again, like I said, it could be diapers, it could be formula, it could be home visiting, like being able to pair up the resources that we have within our state already to the right families within that state. I would love to see more providers, and that is with regards to physicians, with regards to midwives, with regards to family medicine obstetrical providers, more people just talking about the postpartum period and maternal health. That can be through our FQHCs in the state. There's so many places that we can touch people. I want them prepared to talk about it, okay to talk about it, and have a couple of tools under their belt with which they can start every patient kind of on that route, and then a trajectory with which they can follow if they exceed what those resources are in that state. And then I would love to have kind of a maternal health care network with which we've created for our delivering patients so that they can easily stop in one place and get wherever it is that they need to go. And we keep a good line of sight on where our providers are and where our resources are, and being able to pivot those to where the patients need them.
I love that. I'm literally writing that down. Multidisciplinary wraparound care and professional cohort. Be able to share ideas with our professional colleagues, and then be able to provide a multidisciplinary wraparound service for these patients. I love that. Again, we thank our guest, Dr. Manning, for the work she does taking care of Arkansas mothers. We hope we see you back for future episodes of the While You Wait podcast. If you're seeking CE credit, please be sure to follow the instructions in the episode description, and follow or share this episode with colleagues, friends, and family. Until next time, take care.